and welcome to our advocacy and public policy webinar series. And our topic tonight is in regards to, all of the changes that are going on. I think a lot of folks are feeling very overwhelmed by healthcare changes, and so we're hoping that we can begin to kind of shed a little light on what is happening and um, how we can work together to try to address those issues. So, just briefly, I wanted to thank our sponsors who make this webinar series possible. The Bleeding Disorders Council of California, formerly the Hemophilia Council of California, is a nonprofit organization focused on advocating for education and health access for individuals living with bleeding disorders and other rare and chronic diseases. So, Cher is going to join us in just a second, or she is here, but going to take over from me, I should say, in just a second. And in the meantime, though, I did want to give just a little bit of a level set for the conversation. So, just a few quick reminders. What is Medicaid? Medicaid is a federal public health insurance program that was created back in 1965. And today, about 70 million people in the US use Medicaid.
Oh, it
And
finally moved in here?
every state has Medicaid, a Medicaid program, but the program does vary from state to state. It's funded by a combination of federal and state funding. And in California, we call this Medi-Cal. Okay. Who is covered by Medicaid? Children. Medicaid is a major source of healthcare for children, especially those living below the federal poverty level. Pregnant women. Coverage is provided to ensure access to prenatal care and delivery services. I think across the US, it's 40 to 50% of all pregnancies are covered by Medicaid. Seniors, Medicaid helps cover some costs for low-income seniors, including those that are eligible for Medicare. One of the main ways in which we see this is long-term care or assisted living type care, as actually primarily covered through Medicaid. And then people with disabilities, including those who are unable to work or may not be able to access other forms of insurance. And then more specifically in California, we cover about just under 15 million Californians through Medi-Cal, which is and that includes about 50% of all children 17 and under. Medi-Cal also covers about 40% of all births. And in a typical year, about 30% of people with bleeding disorders nationally utilize Medicaid to access care, but in California, that number is closer to 50%. And Medi-Cal, as I mentioned, also provides long-term care for disabled people and seniors. Okay, so with that background, I'm going to turn this over to Cher Gonzalez, our legislative counsel, who is going to take us through kind of what some of the issues are that have happened in the state budget this year that are going to be impacting Medi-Cal, as well as looking forward to some of the provisions of HR 1 that we've all been hearing about in the news, and kind of how we best can guess that that is going to affect us here in California. So, Cher, take it away.
Hi, everyone. I'm just going to give you like the lowdown on HR1, but I'm going to do it in the context of what our budget looks like in the state of California because I'll give an example. I want it to be meaningful for you. So, if your air conditioner system broke down and the contractor said it's going to cost you $50,000 to repair it, that's objectively a lot of money to anyone. But the impact of that $50,000 will be very different to the person who has $500,000 in the bank versus the person who has $500 in the bank, right? And right now, the state of California is the person with $500 in the bank. We don't have money for the services that we are already providing, and that was before all of the cuts that HR1 made. So what does that budget look like in 2025? We just passed the 2025 Budget Act here in California. We had a $12 billion shortfall. Now, we used to say words like deficit, but because we have a rainy day fund, we started moving towards like shortfall. It means our expenses were $12 billion more than the money that we had coming in. So that's what $12 billion shortfall. Now that's before the impact of HR1. Just right off the bat, we were missing $12 billion for all the expenses that we had to pay. The total spending of the Budget Act was very large. It was 321 billion in total spending and 228 in general fund. The good news is we were able to keep some money in reserves, 15.7 billion. But as you can see, when we have a $12 billion shortfall, it's a very scary number that it's only 15 billion for the future that we have left in reserves. Next slide. How did we close this budget shortfall? Well, for the most part, it was a lot of accounting gimmicks. It was like taking from special funds, because remember, the budget deficit is talking about the general fund, but there are all sorts of special funds that we have available. So a lot of it was like maybe borrowing from special funds or shifting funds from special funds to the general fund. There were reductions. The reductions in spending was about 23% of the total solution. So there were cuts, but they really worked to try and avoid too many cuts this year. And so they did things like, okay, well, we're going to defer spending on that new program for a couple of years, and we're going to borrow money from this side and move it over here. And so the total cuts in this budget was only 23%. Next slide. Okay, so what does that mean in terms of Medi-Cal spending? Well, unfortunately, Medi-Cal, when we're looking at the $12 billion deficit, the $12 billion shortfall, half of that came from Medi-Cal spending increases this year. So Medi-Cal was $6.4 billion over their projected spending. That's a big deal when total general fund spending in Medi-Cal was 45 billion, 6.4 billion being half of the 12 billion deficit. That's a really big deal. Now, why was it 6.4 billion more than we had even anticipated? Well, there were a couple of reasons. One was Medi-Cal spending and pharmacy was $1 billion more than they had projected. We'll get to that in a little bit. And the second reason is that costs for those with unsatisfactory immigration status, what we used to call as the undocumented population, we now refer to them as unsatisfactory immigration status, that was $5 billion more than we had anticipated. That's a pretty big deal. Now, why was it 5 billion more than we anticipated? Well, there was greater uptake in primary care and pharmacy spending in that group than people thought that there would be. Next slide. Now let's talk about the Medi-Cal pharmacy spending and let's sort of break that down as why was it 1 billion more than we thought it was going to be? Well, overall, the program has increased in cost. So from 2018-19 to 2023-24, Medi-Cal pharmacy spending nearly doubled. So it's just greater spending in general. Now, what do we know about that is that California launched CalRx in January 2022. Now, what is Medi-Cal RX? Well, Medi-Cal RX is the program where the state said, hey, managed care plans, HMOs that see Medi-Cal patients, we're going to take the pharmacy benefit away from you and we're going to put it with the state in the fee for service. So now everyone in the state, regardless of what managed Medi-Cal plan they're in, are all going to have the same pharmacy benefit. Well, what that meant is the state was assuming all of those costs for pharmacy. So that's one reason why it doubled. But nearly half of that growth, of that doubling, came from the cost of drugs themselves. So part of it, half of it was because they moved over to fee for service and the state assumed all the costs for pharmacy. But the other half was certain drugs, and those drugs were for diabetes, obesity, and inflammatory diseases. This budget in 2025 sought to address those pharmacy concerns in a number of ways, and I sort of list them here. Requiring pharmaceutical manufacturers to provide a minimum rebate for cancer drugs and HIV drugs, eliminating coverage for pharmacy over-the-counter medications, requiring utilization management and step therapy protocols. This is the one I think is the most important for our community. Is they're going to start requiring, they did pass it in the budget, they're going to start requiring in Medi-Cal prior authorization for continued therapy. So you may have always been on your current blood factor and never had a problem because this is the same blood factor you've always been on, but you may experience problems in the future once they implement prior authorization for continued therapy. So there are a number of things that they did to address that $1 billion. The solutions don't really quite add up to $1 billion. So I would assume we may see additional focus on pharmacy spending in the future. So we shall see, especially since they specifically listed inflammatory drugs, diabetes, and obesity. Now, I know in this budget, they did eliminate coverage for obesity medications in Medi-Cal. So they did address obesity. What they will do in inflammatory diseases, I'm not know. They could do something like they did in cancer and HIV, which is to require a minimum rebate. We shall see what they choose to do in the future. Next slide. Now let's set the stage on what do the future deficits look like. Okay, we had $12 billion in a deficit, but we did close it and have a balanced budget. But what does it look like in the future? Well, it depends on who you ask. The Department of Finance works for the governor. And according to the Department of Finance, California is expected to have deficits anywhere between 10 billion to 20 billion over the next few years. But according to the California Senate Republican Fiscal Office, that number is more like 17 billion to 24 billion. And while that doesn't maybe seem like that big of a difference, we're talking about billions, right? So that's kind of a lot of money. So what everyone agrees on is over the next few years, we're going to have major deficits. But according to who you ask, what those deficits look like, it's kind of a different story. 10 to 20 billion over the next few years from the governor's office and 17 billion to 24 billion from Senate Republicans. Next slide. Now there's something called a managed care organization tax in California that provides a huge amount of funding to the Medi-Cal program. Now we'll get into this in a minute, why I'm even talking to you about this. But just to set the stage, the managed care organization tax in 2024 through 2025 provided $9 billion to the Medi-Cal program. Now, you may recall me saying in a different slide that current Medi-Cal general fund spending for this year was $45 billion. So $9 billion is like what? Like almost 20%, right? That's a huge percentage of our general fund spending. In 2025-26, it was 4.2 billion, and it's projected in 2026-27 to be $2.8 billion in revenue to fund the Medi-Cal program. Next slide. Now let's get into like, why am I even telling you these things to begin with? And it was all, remember, to be setting the stage so everyone understands what's really at risk when we're already broke. HR 1 has several provisions regarding Medicaid, and those are basically in three buckets. One is on eligibility and access, such as work requirements and eligibility checks, retroactive coverage. Another is on how the state finances their Medicaid programs, and that's where we're talking about the managed care organization tax. And then the third bucket is on immigrant coverage limitations. Next slide. All right, so let's talk about those access issues. Starting January 1, 2027. Now, what does January 1, 2027 mean to all of you? I know what it means to me, and it means it won't be Governor Newsom's problem. It will be the next guy's problem, right? Because Governor Newsom only goes through 2026, and the Monday after January 1, 2027, the new governor is sworn in. So, that's why we have a little bit of leeway on this, although I do believe the California legislature will be needing to come up with some solutions. But on January 1, 2027, certain requirements are going to be required to be implemented by states. One of them is work requirements. For any individual aged 19 to 64, they're either going to have to work if they're to receive Medicaid, or they're going to have community involvement, volunteering sort of requirements. Now, there are exemptions to this. For example, people who are considered medically frail, and that includes people with physical disabilities, intellectual disabilities, developmental disabilities. There's quite a list on who is actually exempt from that requirement. The problem is that exemption actually has to be verified once every 6 months. So if you are a developmentally disabled individual who is receiving Medi-Cal, you're going to have to verify every 6 months that yes, you are still developmentally disabled. Imagine if you had to, verify your driver's license once every 6 months. How burdensome that would be. Now imagine if you had to do something as a developmentally disabled individual and verify that every 6 months. They also limited retroactive coverage, which is a bigger deal for some than others. They limit currently if you go through the Medi-Cal process, which is quite lengthy, and you're finally approved for Medi-Cal, they will make your coverage retroactive for 3 months prior because the process does take so long. They have now limited that to 1 month. So that's going to have a huge impact, not just on certain individuals, but also to the providers who are seeking to be reimbursed for the care that they have provided. On October 1, 2028, they're also requiring states to implement cost sharing. So, for example, states would decide the amount of the copayment that an individual would have to make. It would not be able to exceed $35 per service, and it would be subject to an aggregate limit of 5% of the family income. This is only for people with incomes above 100% of the federal poverty level. Now, what does that mean? What is 100% of the federal poverty level? Well, in California, that's defined as for one person, a salary over $15,000 a year. For a family of four, it's someone who makes more than $31,000 a year for the family of four. They would have to have some type of co-payment or cost sharing placed upon them by the states. This bottom line impact to California and their Medi-Cal requirements contained in HR 1 means that California will lose around $30 billion annually. I'm going to talk about it's not just this provision, but it's all of the Medi-Cal provisions, the Medicaid provisions in HR 1. But the result of all of these is $30 billion loss every single year to the state of California and federal funds for the Medi-Cal program. Directly, the access provisions that I'm talking about, though, will result in 3 million Medi-Cal members likely losing coverage. And quite frankly, to be cynical, I do believe that that's one of the reasons that they made this 6-month eligibility verification for the exemptions every 6 months, because they know people will just drop off the rolls. Next slide. All right, so now we're going to get into that managed care organization tax and why I was even talking to you about that to begin with. It's because remember all that money I was talking about, like in 1 year, we got $9.4 billion, almost 20% of our Medi-Cal general fund spending just from that tax. Well, apparently that tax that we currently have on the books does not comply with the federal law, and that starts now because as of July 4th, 2025, there are certain prohibitions on how a managed care organization tax can be structured, and ours is not compliant. So that's going to be a problem. Now, the HHS, the federal HHS, has the discretion to grant states a transition period of up to 3 years. So cross your fingers that we get that. But last time I checked, California's administration and the federal administration weren't getting along too well, especially on Twitter. So, it's not guaranteed that just because we apply for a transition period of up to 3 years to get our managed care organization tax compliant with the federal requirements doesn't mean that we're necessarily going to get it. What it does mean is that the state is going to need to the legislature is going to need to consider certain changes to our managed care organization state structure and state law, and then try to change the managed care organization tax law to be compliant with the feds. Again, this is a lot of money on the table. And there are some people who are like, well, I don't even know how we're going to make our managed care organization tax work. I certainly believe the legislature will try and, as well as with the governor's office, try to come up with a plan to change the law so it can be compliant with the federal law. But this is a lot of money that's now left on the table if we can't get this going. All right, so immigration, so moving off of state financing provisions in the managed care organization tax, on immigration, there are certain coverage limitations that did pass in HR 1 that's going to require California to come up with a plan, because right now, the feds will provide 90% federal fund match for emergency Medicaid services that are provided to people with unsatisfactory immigration status, right? HR 1 says, no, we're not going to do that anymore. Well, so now we're going to need to figure out what we do, because that's a lot of uncompensated care that hospitals will now have to pick up the tab for. And so what are we going to do as a state? Are we still going to provide that as a Medi-Cal reimbursement so that our hospitals aren't going under? I don't know, but these are the sort of the questions that the California legislature will have to answer. Next slide. Also, full Medi-Cal. So full scope Medi-Cal is provided to other types of immigrants. So this is not unsatisfactory immigration status. This is not the undocumented. These are people with satisfactory immigration status. So refugees, asylees, victims of human trafficking. Victims of human trafficking are entitled to a T visa, a trafficking visa. They are here legally. And previous to HR 1, the feds would provide a federal match for these individuals. Unfortunately, that's all going to change. And the result to California is that approximately 200,000 immigrant Medi-Cal members will shift from satisfactory immigration to unsatisfactory, as in they will not be able to get the full federal financial participation in for a full scope Medi-Cal. So California needs to decide, well, what do we do about that? Do we pick up the tab even though the feds are not going to be matching these funds? And if we don't pick up the tab, then what happens to our hospitals? Because when a person who is working has a heart attack, they're going to go to the emergency room, right? It's not like the hospital is going to say, oh, well, we can't take care of you. You're almost dying and you have a heart attack. And that becomes the uncompensated care question. So California has a lot of questions that they need to answer in the next year and in the coming years. Okay, next slide. There is some amount of good news. It's not a bunch, but they do take this into account for rural hospitals that are already struggling. So rural hospitals, rural health providers, states can make an application to request funding from the rural health provider fund. I can't remember the exact name for it, but that's $50 billion that was allotted in HR 1. But that $50 billion is not like all at once. It's $10 billion each year from 2026 to 2030. And how is that money, if you apply, will it be distributed, right? So 50% will be distributed across the states equally. So everyone gets the same amount, 50% of that 10 billion, right? And then 50% will be distributed to states per CMS's discretion. And again, this gets to the fact that our California administration isn't getting along too well with the federal administration. And so will they grant California's application? They'll need to make an application for these rural health funds. But would that be granted? Would that other 50% be granted? And I don't know. What we do know is the state really needs to submit that application, and CMS is required to approve that by December 31st, 2025. So that's going to take now action. That's not something for the future. That's like, we need to do that now. Next slide. So looming ahead is also Covered California. Covered California is our insurance marketplace. So we're leaving behind Medicaid and we're going now over to Covered California, which is commercial insurance for many people. But many people who get commercial insurance from Covered California get tax credits. Well, HR 1 did not include the extension for the federal premium tax credits for the marketplace consumers. And if they don't act soon, those tax credits will expire on December 31st, 2025. And if those tax credits do expire, Covered California enrollees will face an average of 66% increase in their monthly premium costs. Now imagine any one of your bills going up 66% like that. Many of us could not afford that, right? So what California is estimating is that if Congress does not act and pass an extension, then that means 400,000 Californians will lose their commercial insurance altogether. Next slide. And this is just a graph that shows you just how much the premiums will go up if those tax credits are not extended by the end of the year by Congress. There's another provision in HR 1 that is going to impact Californians, but is also going to significantly impact the California budget situation. And those are changes to the Supplemental Nutrition Assistance Program, or SNAP. People, you may have heard the term before, food stamps. No one uses that term anymore, but it's sort of an antiquated term that many people may not know what SNAP is. Because of changes to SNAP, California is estimated to lose $1.7 to $3.7 billion every single year just because of the changes to SNAP that are included in HR 1. Next slide. Okay, so back to the bottom line impact. What does this mean in the terms of California's budget situation, right? So California Health and Human Services Agency estimates that we will lose $30 billion in federal funding every year. That's a lot of money when our general funding spending on Medi-Cal is only $45 billion. So you can imagine how much $30 billion is, right? And then changes to the SNAP program, it's $1.7 to $3.7 billion that we're going to lose annually. And remember, we just fixed a $12 billion budget problem. Now we're going to perhaps add as much as $33 billion in a shortfall to that 12 billion number we already had this year. Now you can see how big this problem is. According to the California Hospital Association, the changes to Medicaid are going to significantly impact the revenues to California's hospitals, and they anticipate that the revenue losses to the hospitals are going to vary between $66 billion and $128 billion over the next decade. What does that mean? We could very well see hospital closures. According to the California Medical Association, changes to Medicaid in HR 1 will result in huge healthcare contraction to the healthcare system and possibly eliminate 217,000 healthcare jobs in California, reduce economic output by 37 billion, and uncompensated care is anticipated to surge to $9.5 billion over the next decade. And that's going to put further strain on our hospitals and our providers. So we have quite the problem on our hands that we'll need our legislature and our governor to work to fix. So next slide. So what will the California legislature do? Well, we know one thing that they've said that they're going to do. The California Senate said they're going to work on developing a plan to create additional revenue. Now, how are they going to do that? Their proposal is often referred to as the Walmart tax. Why is it called the Walmart tax? Because it would be a tax on very large employers who have a very large percentage of their workforce who are on Medi-Cal. So that's why it's often called the Walmart tax, because Walmart is often criticized for making virtually all of their workforce part-time. So they are the working poor. And as a result, because they make so little money, they don't have healthcare benefits from Walmart, so they go on to Medicaid, right? And we know that a significant portion of Walmart's workforce in California is on Medi-Cal. So some people are calling it like a user fee. You don't want to pay that user fee, then stop hiring nothing but part-time employees and make them full-time and give them healthcare benefits, right? So that is one option that the California Senate has already floated. Don't know where that's going to go, but that's one option to bring in more revenue to the state. What we know from the California Assembly is that there could be possible action on the budget this fall, even after we gavel down on September 12th. The legislature ends their session on September 12th. No doubt we'll probably have a few budget bills that pass before September 12th, but they may come back to town in the fall to deal with this budget problem. And then we certainly know that they'll have to probably have early action in January when the governor releases his budget proposal, somewhere after January 10 or around January 10. And then the Legislative Analyst's Office is the nonpartisan arm, fiscal arm of the legislature. And what they have said about this problem is that the legislature will likely need to adopt additional solutions that increase revenues or reduce spending. So next slide. So you can see there are a lot of things that they need to do. They need to submit an application for the Rural Health Transformation Plan. There's the name. I forgot the name of it when I was talking earlier, but it's the Rural Health Transformation Plan for the Rural Health Provider Mitigation Funds. They're going to have to submit a plan for that, and they're going to have to do that soon. It's due by December 31st, 2025. They're going to have to restructure that managed care organization tax. That's going to require legislation. And there's also a hospital quality assurance fee that's not compliant with HR 1. They're not going to need to do something about that. They're going to need to address how do we provide care for the undocumented and also the immigrant populations that currently are satisfactory immigration status, but HR 1 is yanking the funding for them. What are we going to do about that? I don't know, but they're going to need to come up with a solution about how they're going to fund that, or how they're going to try to help hospitals who are now going to have to pick up the care that's being provided to a population, but now there's no Medi-Cal reimbursement for it. Are they going to address Medi-Cal pharmacy costs? I don't know. There's a possibility maybe the future governor says, you know what, that Medi-Cal RX idea about everyone going to the state for their pharmacy benefit, I don't like that. I want it to go back to the managed care organizations. That's a possibility. Will they focus on the anti-inflammatory drugs that they say are like 50%, along with diabetes and obesity, 50% of the increased Medi-Cal spend? I don't know. Are they going to cut Medi-Cal provider rates in the future? For those of us who are around for the Schwarzenegger administration, that's certainly what he did. He did 10% across the board cuts. I don't know if that's an option for them, but just talking about what's happened historically when we have huge budget shortfalls. Are they going to cut Medi-Cal benefits? It's always an option too. There are certain benefits that the state doesn't have to provide that they could always cut, such as, for example, something like podiatry benefits or acupuncture. There are a number of benefits that they could cut that are optional for the state. And then finally, are they going to pass new taxes? Are they going to raise existing taxes? Are they going to eliminate tax credits? There are a whole bunch of solutions out there to them, but our problem is so large that I don't know if they can cut their way out of this problem alone without raising revenues. So to be determined. Next slide. I think that's the end of my slides, is it not?
Yes.
All right.
Thank you, Cher. Um, I kind of am thinking about this as I did this, and I was like, I gave you the really kind of crummy job because that was a lot of bad news that you had to give us. So I apologize for that. And I know we're a little bit over time, but I want folks, hopefully you'll bear with us because we do have a few suggestions for our community members who just heard all of those updates and are thinking, oh my goodness, what am I going to do? And one of the first things that I want to encourage everyone and remind them is that they these a lot of these changes are not taking place immediately. So we have some time to try to address them and figure some things out, particularly the changes related, as Cher mentioned, the changes related to like the new um, adjustments that would require folks to redetermine every 6 months, as well as the issues with work requirements. Those will not take effect immediately. So with oops, hold on. Apologies. A little technical issue on my end, so hold on just one second. Can everyone still see the slides?
Yes.
Oh, okay. Excellent. It changed, somehow I changed my view and I couldn't see them anymore for a second. Okay. So here are some tips on what you can do. So, first of all, know what kind of insurance you have, right? Um, Many people have been hearing about Medicaid in the news, right? And you may or may not have understood that Medi-Cal is the Medicaid program in California. In addition, I sometimes have folks come to request assistance and I say, hey, do you know, is this a Medi-Cal plan? And they'll say, oh, no, I don't have Medi-Cal. I have, you know, Kaiser or HealthNet or United Healthcare. Well, all of those companies have Medi-Cal managed care plans. So you may have Medi-Cal, and then you're on a managed care plan, and so you have a card from that managed care company. So I think the first step is always to make sure, know what kind of insurance you have, know if you are on Medi-Cal, and if you have a managed care plan. Be sure that your contact information is up to date with Medi-Cal or with the state. And the state has a website for Medi-Cal where you can log in and you can check on the status of your Medi-Cal account. And they also have an app that you can use. I think understanding how both of those work will be a big help for folks that are having to navigate this, especially when the time comes that you do have to start submitting information more frequently. Being able to do it electronically through the website or the app will definitely help you manage all of that paperwork in a way that hopefully keeps you from losing your coverage during those windows of time. Make sure that you open all your mail and your emails from Medi-Cal and or your managed care plan and respond within the deadline, okay? With it, typically that's 10 to 30 days. It's very important that you do stay on top of that and don't ignore mail from your insurance company or from Medi-Cal. Sometimes we can be tempted when we're afraid something's going to be bad news to just ignore it, right? Like, oh, I don't want to open that. I think it's going to be bad news. But that's when you can really get into problems, right? You don't want to lose your coverage just because you missed a deadline. And then, begin keeping records of your monthly work or qualifying activities. So there are going to be exemptions, and Cher mentioned that, right? There will be exemptions to the work requirements. We are still waiting for the federal government to release the more guidance for the states on like what's going to qualify someone for those exemptions. So we don't have all of the details on that yet, but we do know that besides work, some of those qualifying activities could include caregiving to other family members, like children or elderly relatives. It could include going to school, and it could include things like community service. So those are great resources and things to begin to think about how are you going to track that. Okay, let me go. Oops. Okay. Oh, apologize. For some reason, it's not going to let me share the slide or move the slide. Let me redo that. Okay. Here we go. So, covered California as well. We talked a little bit about the potential impact on premiums with covered California. A lot of the same suggestions. Make sure that right now you stay up to date on your premiums and that you read all the notices and submit responses by the deadline. There was a question in the chat about enrolling, sooner rather than later. I would definitely say so. Enrolling now doesn't necessarily mean that you will not be subject to premium increases, but there may be different paperwork required. And so I would not wait till the last minute to enroll for 2026 so that you have time to get together all of the documents that you need. Be aware that premiums are likely going to go up. And then, make an active choice for 2026, even if you're keeping the same plan. And then also protect yourself from junk insurance. Junk insurance is, if you just go Google ACA plans, the first like page of results are typically like scams, basically, not real insurance. So make sure you're going to Covered California directly for that information so you don't get caught up in a junk insurance plan that really isn't going to cover you. And then the big shining light for the bleeding disorders community and for some of our other rare disease partners like sickle cell and cystic fibrosis, and there's some other diseases covered, is that as of right now, there are not any changes planned for the genetically handicapped persons program or GHPP. So those people who have a qualifying condition who are currently on Medi-Cal or on a covered California plan. If you think that these changes may put you at risk of losing your coverage, then I would encourage you to go ahead and enroll in GHPP immediately. It will be your secondary insurance for now. But then if you were to lose coverage from Medi-Cal or Covered California, it would just automatically switch over, and GHPP then would become your primary insurance. And so that we are not, I'm not going to go into the details right now for the sake of time of how you go about doing that, but we do have webinars on our YouTube channel that talk about how to enroll in GHPP, and you can certainly contact us for assistance. And then as it relates to the ACA, there is something that we can do right now, and that is Congress still has the opportunity to act and extend these tax credits. So if you are on your phone, you can take a picture of this screen, and then you can use that photo to be able to click on the QR code or type in the URL, or if you're watching on your computer, maybe you can use your phone to scan the QR code, and that is going to take you to a campaign that was set up by our partner, the National Bleeding Disorders Foundation, and it will help you. It basically, you click on there, you put in your name and email and your address, and it will pull up a draft letter that you can send as via email to your congressmen and your senators, urging them to extend the healthcare tax credit. So I would really encourage folks to do that. And really do that regardless of whether you personally are affected by the covered California plans, because if the plans end up losing like millions of covered California, or not just covered California, but millions of ACA plan members across the country, it will affect everyone's rates, regardless of whether you're on an ACA plan or on like an employer-based plan. It's going to negatively impact the rates for everyone. And so we really need to encourage folks to take that action. All right. Let me take a look in the, I'm going to leave the QR code screen up rather than going to our question and answer page, just in case somebody wants to do that. And kind of, I'm going to scroll through the chat here and see if there's any um, questions. Okay. So first of all, someone asked if IHSS counts as income. So if you are being paid as an IHSS worker for another, family member or someone that you're working for, then those dollars would be income. If you're receiving that in benefit, then you probably, I don't know for sure with all the changes how that's going to impact eligibility. So you can always feel free to clarify that question a little bit in the chat, and maybe we will do our best to answer it. Good suggestion to advocates and patients. Start journaling what's happening to you or your family members or your community members, and then share that information with us, with other patient groups, because the more stories that we can tell, the more that's going to help us be able to get the word out and let legislators know how this is impacting their constituents. And also be sure that if you are receiving denials from your insurance company, make sure that you're going through the appeals process. And then also, you can also appeal that with the Department of Managed Healthcare here in California, which is important because then that helps them to track things. Shared in the chat the link to the Medi-Cal page that lets you see your account and submit documentation. So check that out if you haven't looked at that before. There was also a question about CCS. As of right now, both CCS and GHPP, have not been any proposed changes to those programs. I will say I am concerned in the long term. I think Cher presented a very complete and accurate picture of just how bad this budget situation is. And so, given that, I am concerned that in future budgets, they may have to look at the cost of CCS and the cost of GHPP. But in the immediate, those those programs are continuing to move forward as we've known them these last couple of years. And so that's good news. And, we'll continue to utilize those to benefit our community in the meantime. There is a question, will pharmaceutical companies have to step up and help with coverage of more costly drugs, for example, their patient assistance programs? I do think that is something that they are going to have to think about. More people losing coverage means more people will be seeking that assistance. Now, if you're on Medi-Cal or Medicare, you're not allowed to use patient assistance programs. But we're just going to have to see how all of that pans out. It'll be more the people who lose insurance altogether that will probably be impacted by that. Um, Let's see. Somebody asked if I have GHPP, could I not have covered California or vice versa? So the answer to that is you can always have GHPP with other insurance. Whether it doesn't matter, it could be employer-based insurance, it could be Medi-Cal, it could be Medicare, it could be a covered California plan. The GHPP will always be the payer of last resort, meaning that if you have another policy, that will be what is the coverage that is utilized. And in that case, GHPP would only kick in if you were denied coverage of, say, your blood factor, for example. If your insurance says, no, I will not pay for that, and you have GHPP as your secondary, then your GHPP would kick in and cover that. But GHPP will not cover copays. So, like if you have a copay on your insurance, it's not going to pay that difference. So hopefully that helps. Clarify that question. And then what about if you can't work because you have kids with special needs? So I know that in the work requirement, I believe that if the children are under the age of 14, then that counts, then your time you can be identified as a caregiver. Now, as Cher said previously, the annoying thing is you're going to have to re-document that every 6 months, right? And then I think I would imagine that there are also provisions if they are older than 14, but they have special needs and you're providing caregiving to like a person who is disabled. Again, same thing. That should qualify as working, but you are going to have to document that. Let's see. Yeah, and Sharon answered that in the chat already. Um, see. I think that is all of the questions. Thank you all for hanging in with us this evening. I hope that you found this helpful. I know that it was not the best best news in the world, for sure. We're all concerned about the status of these programs and folks being able to access them. But I do just continue. I'd encourage you to try to stay informed, pay attention to the updates from trusted sources. And we will continue to do our best to provide information that hopefully will be helpful to people throughout the process as we get more information. So, appreciate you joining us this evening and sticking with us. We went a little long tonight. And thank you again, Cher, for that detailed explanation. And next month we will be doing this type of a webinar again, focusing on a little bit more on what's happening with the ACA marketplace and how people can make sure that they make the right selection with that or their employer plans, as we're coming into open enrollment for a lot of folks. So hope you'll be able to join us again next month. And thank you again. Good night.